Just imagine the incredible breakthrough, administering anticoagulants in the ICU without the constant worry of causing a bleed. The medical world stands on the brink of a revolution that could redefine patient care. Join us as we delve into this game-changing discovery that might just make this dream a reality. Bleeding and thrombotic complications lead to significant morbidity and mortality in ICU patients using percutaneous mechanical circulatory support like ECMO, balloon pumps, and microaxial flow pumps. This situation arises due to coagulopathy during critical illness, sepsis, inflammation, platelet consumption, hyperfibrinolysis, shear-induced acquired von Willebrand syndrome, direct contact pathway activation by the PMCS device's artificial surface. Anticoagulation is crucial to prevent thrombotic complications and device-induced localized intravascular coagulopathy. However, the anticoagulants used currently increase the bleeding risk, impacting patient outcomes. The ideal anticoagulant would prevent thrombosis without affecting hemostasis, thereby minimizing bleeding risk. Anticoagulant drug development began with heparin and warfarin in the early 20th century. Recently, most anticoagulants target the common pathway, influencing factor 2A or factor 10A. Citrate is an exception, working through calcium chelation and pH changes. All these anticoagulants come with a bleeding risk. New anticoagulants, known as the new kids on the block, have been introduced. These are contact pathway inhibitors targeting factor 11 and factor 12. They've gained attention due to epidemiological data from genetic disorders related to these coagulation factors. Individuals with congenital factor 11 deficiency rarely have spontaneous major bleeding, have a decreased risk of venous thromboembolism and possibly acute myocardial infarction, may have an increased risk of minor bleeding after trauma or surgery, especially in mucosal tissues like the oropharynx, nasopharynx and genitourinary tract. Particularly those with severe factor 11 deficiency, that is less than 1%, display a bleeding tendency from reduced clot formation and higher susceptibility to fibrinolysis. This can be addressed using antifibrinolytic agents like tranexamic acid. There's a need to find the optimal factor 11 inhibition level to balance against mucosal bleeding risks. Patients with factor 12 deficiency don't display a clear clinical bleeding phenotype. For both factor 11 and factor 12 deficient individuals, the activated partial thromboplastin time is notably prolonged. The prothrombin time remains unaffected. The reason for FXI and factor 12 inhibition separating arterial and venous thrombosis from hemostasis during vascular injury is because such injury doesn't always amplify thrombin generation via the contact, intrinsic pathway. In an ICU setting, contact pathway inhibition could be beneficial. Factor 11 and factor 12 are activated by the negatively charged surfaces of materials like catheters, cannulas, or devices commonly used in the ICU. For patients on PMCS, inhibiting the contact pathway could revolutionize treatment by addressing LIC and device-related thrombosis without the heightened bleeding risk associated with other anticoagulants. If you're finding this information valuable, hit that subscribe button below and tap the notification bell. Stay with us for more in-depth insights on ICU advancements. Currently, 3 classes of factor 11 and factor 12 inhibitors are under clinical trials. 1. Factor 11 antisense oligonucleotides that reduce plasma factor 11 levels by binding to its messenger RNA. 2. Monoclonal antibodies. 3. Small molecules that bind factor 11 or factor 12. In addition, natural inhibitors from sources like ticks and AP tamers are in preclinical development. Phase 2 trials. Supportive data from Phase 2 trials indicate that factor 11 inhibition can reduce bleeding events in several conditions: thromboprophylaxis in orthopedic surgery, atrial fibrillation, post-stroke, post-AMI, hemodialysis. Focus on safety. These Phase 2 studies primarily aimed at assessing safety, ensuring no increased risk of bleeding. Phase 3 trials. These are currently underway for VTE prophylaxis, AF, stroke, AMI. Preclinical data on PMCS. 3 factor 12 focused agents, including 2 antibodies and 1 small molecule, demonstrated thromboprotection in animal ECMO models. A specific factor 11 targeting small molecule showed promising results in a canine ECMO model. Factor 11 or factor 12 depletion using ASOS in a rabbit model extended ECMO lifespan, minimized thrombotic complications, and maintained fibrinogen levels. Factor 12's dual role: it intersects hemostasis and inflammation, activates prekallikrein to kallikrein, influencing the complement and bradykinin pathways. Significance in ECMO: membrane oxygenator fibers in ECMO can significantly generate thrombin in an factor 12 and factor 11 dependent manner. This highlights the unique roles of factor 11 and factor 12 in ECMO settings. Broader applications: encouraging evidence has prompted research into using these molecules for conditions like end-stage renal disease, renal impairment, cancer, ICU gap. No current trials focus on FXII or FXI inhibition concerning mechanical device-associated thrombosis in the ICU. This is despite the promising potential of contact pathway inhibition, particularly against coagulopathy induced by plastic surfaces. Advancements in anticoagulation have the potential to redefine ICU treatments. Now is the time to prioritize research on factor 11 and factor 12 inhibition. For the sake of our critically ill patients, let's harness this potential and usher in a new era of safer, more effective care. Act now. The future of ICU medicine is in our hands.